I'd like to introduce the next speaker, Dr. Peter Kirkbride, who's one of my colleagues. We work together in Sheffield. Peter is a clinical oncologist, a radiation oncologist. He's going to give us the benefit of his wisdom on treating prostate cancer, localized prostate cancer, probably, with external beam radiotherapy. Thank you very much. We're running slightly over, but I think we'll need some tea break. Is that okay?
When I prepared this talk, I wasn't quite sure what the audience was going to be. Now, I've made an assumption that you're mainly clinical nurse specialists, and John has shown that's the case. But can I just check, does that mean most of you are not intimately involved in radiotherapy decision-making and radiotherapy treatments? Is that correct? So if that's the case, what I'm going to do when I start is actually, before we talk about advances, is talk about where we're advancing from, and give you a little bit about the basics and background, the current state of the art, how radiotherapy has been over the last decade, and then talk about where we're going in the future. So I'll do a bit of background talk, then I'll talk about 3D conformal radiotherapy, which has been the sort of state of the art over the last decade, and in that I'll include some recent advances in the use of radiotherapy post-operatively, and also the recent data on the use of radiotherapy for locally advanced prostate cancer, before moving on to the thing which probably the helpline gets phone calls about, things like intensity modulated radiotherapy, image guided radiotherapy, types of brachytherapy, protons, stereotactic radiotherapy, including the cyberknife. And at the end, so we don't forget about it, let's just mention palliative radiotherapy for patients with hormone resistant disease. Now, clearly I'm going to be referencing papers from very important journals. I'll state from the beginning that I'm not going to use any articles from the most influential UK prostate cancer publication. But it is, isn't it? This is what they wave when they come in to see you. And some of the things that I'm going to talk about have appeared in the Daily Mail and the Express, etc. But I have to say, don't believe everything you read in the Daily Mail. In fact, don't believe hardly anything in the Daily Mail. And what I'll try to do today is try and flesh out some of the information about those things so that you're more accurately informed. So, let's just have a little 5-minute radiotherapy 101. So some factors that affect outcomes and effects from radiotherapy. The volume that we irradiate, whether it's big or small, where in the body we're irradiating, the total dose of radiotherapy we give to the patient, how fast we give it, and the fraction size, what size the packets of radiotherapy that we use each day. Because the side effects will depend on the area irradiated. If you irradiate the stomach, then you'll get nausea and vomiting, but not if you irradiate the limb. You'll only get radiation cystitis if you irradiate anywhere near the bladder. A higher total dose will increase the risk of the acute short-term side effects. So the higher the total dose, the more likely you are to have problems in the short term. But in terms of predicting for long-term side effects, as well as the total dose, it's equally important as to how much radiation you give per day, the fraction size. Those acute effects are inflammatory, they're very common, almost inevitable in high-dose radiotherapy, and almost always resolve completely. But the late effects, which are not inflammatory, they're due to effects on vasculature, they are permanent, but may take months or even years to develop. So we accept that it will cause acute effects, but we try and avoid late effects if at all possible. We traditionally use megavoltage, high voltage energy beams, which have the advantage of skin sparing, meaning the radiotherapy dose is not delivered fully until 1 centimetre or 2 below the skin. And that is why you no longer get the old radiotherapy burns. There's a difference between radiotherapy when you're giving it with radical intent and when you're trying to palliate it. When you're trying to cure someone, you want the highest possible dose that you can give to give the highest possible cure rate. As I've mentioned before, you want relatively small fraction size to minimise the risk of late damage. So in general, we've given fraction sizes of about 2 gray per day for radical treatment. What this means is that patients having curative radiotherapy will have multiple fractions over several weeks. As I've said, the acute effects are common, but the late effects should be rare. That is in distinction to palliative radiotherapy, where late toxicity is less relevant because of the patient's life expectancy. Therefore, we can use larger fraction sizes safely. We don't need to use a very high dose because we're not trying to eradicate every single cancer cell. We're simply trying to shrink it enough to improve symptoms. Therefore, the number of visits can be much smaller, perhaps 1, perhaps 5, which is also good for the patient as it reduces inconvenience. If we move to radiotherapy for prostate cancer, which is why we're here this afternoon to talk about it, again, if Jim Cato's still here, Jim's gone, I have to say, yes, Jim, you're right. There are a few very randomised studies, but those that do exist have shown improved disease-free survival for surgery over radiotherapy. But those trials were done quite a long time ago and have been criticised, and certainly radiotherapy techniques have improved since then, but to be fair, as we've just seen, so have surgical techniques. There are some single institution data suggesting the results of radiotherapy and surgery are comparable, but recent series, not randomised trials, still suggest that perhaps surgery are better, but there's this problem of patient selection. Those of you involved in the PROTECT trial, though, will know that this is a prospective, randomised trial where patients are randomised to surgery or radiotherapy and, of course, to active surveillance. And in due course, although it will take some time, we may have some better information about the comparative benefits of radiotherapy and surgery. So, where have we been with radiotherapy for the last decade or so? The original techniques were pretty damn crude from the 1960s and 70s. They aimed to treat the prostate, the surrounding tissue, and the pelvic lymph nodes, although the RTOG study published in the 1980s suggested there was no benefit from treating pelvic lymph nodes. And so certainly in the UK, since then, we've not used pelvic radiotherapy as standard, and we've just used radiotherapy to the prostate. What's come on recently, or should we say over the last decade or so, is the use of neoadjuvant hormones to improve the outcomes from curative radiotherapy. Now, I'll be honest with you, this began in Canada in the early 90s, and it began because of waiting times for radiotherapy as a holding mechanism, because the waiting times were 12 weeks. But the use of these drugs have shown to reduce the size of the prostate and the PSA level, and there is now evidence that that manoeuvre is actually beneficial. And the RTOG trial did show that using neoadjuvant hormones for 4 months improved disease-free survival, if not overall survival, for patients having radical radiotherapy to their prostate. And a subsequent Canadian publication showed that there was no difference between 3 months of neoadjuvant hormones or 8 months. So more than 3 doesn't appear to be better. So my practice is to offer patients a minimum of 3, but these are prostate cancer patients. They are going for Lanzarote next spring. They don't want to start just before then. So it's okay to have 4 months or 5 months, and then we can work around holidays and Christmas and anniversaries and the son's wedding and things like that. 3D conformal radiotherapy has been standard over the last decade. Prior to that, it was quite crude and was what we called a 3 or 4 field box. And it involved irradiating basically a cube of tissue in the pelvis around the prostate. 3D conformal used multiple beams using computer-aided planning to configure the radiotherapy beams to conform to the prostate much better, and also minimise the dose to surrounding tissues, particularly the rectum, which is the main organ at risk. So what we do in 3D conformal radiotherapy is that we contour the entire prostate and then add a margin, usually about 1 centimetre, to allow for patient motion during treatment and day-to-day variability in setup. We also contour the seminal vesicles, although in people with low risk of seminal vesicle involvement, that can be reduced, and then we can actually calculate the doses to the critical normal tissues. Now, how does this project? Okay, yeah, not too bad. This is a typical set of CT pictures from a patient having conformal radiotherapy of the prostate. And what we've done, as the oncologist has done, is outline the prostate, which is in yellow. He's outlined the organs of risk. For example, the rectum is in orange, and you can see them in both 2D and 3D layouts there. And you can also see that there's a margin around the prostate. There's the yellow of the prostate, and around it is this margin, one centimetre margin, which we put on because of that day-to-day variability, etc. And what we're trying to do is give a higher dose of radiotherapy as possible to the area inside there, and as low doses of radiotherapy as possible to the rectum and the other normal tissues. And when 3D CRT came in, it showed there was better PSA responses, there was reduction in toxicities, and this then began to the work in America of dose escalation. And what we've been doing over the last decade or so is starting to escalate the dose in America using 80 and sometimes even 90 gray. Now, traditionally, in the UK, the doses varied from 55 in 20 to 64, 66 gray in 2 gray fractions using conventional techniques. And I'll just pause at this point because you've noticed that 55 in 20 is not 2 gray per day. And historically, when radiotherapy in the 60s was in very short supply in the UK, a lot of centres in the north, in particular, compressed their radiotherapy fractionation over shorter periods of time simply for expediency. In general, that's now fallen out of favour because radiobiologically it's not very sound, with the possible exception of prostate cancer. And it looks like prostate tissue has a different, what's called alpha-beta ratio, which means that it may respond better to higher radiation doses per fraction. And that's something the Americans didn't believe until Laurence Olivier published his autobiography. It's true, this is true. Larry Olivier had prostate cancer in 1967, and he was treated down the road here at St Somerset's by a colleague who actually believed passionately in hypofractionation and treated his patients in 6 fractions of 6 gray over 3 weeks. Larry Olivier died prostate cancer-free 22 years later. He was cured by that. And no one picked that up until the late 80s and 90s that, you know, you can actually cure prostate cancer like that. And it was brought to prominence by a radiologist in the late 90s. And since then, the Americans have now started to become interested in hypofractionation. And as I explained a bit later on, future advances in prostate radiotherapy may involve going back to hypofractionation. Anyway, that's an aside. Stage left. 3D conformal therapy, as I say, was aimed to increase local control without increasing morbidity. And this is what a 3D conformal radiotherapy plan looks like. And this is much better than the old radiotherapy. The high dose of radiation is the red, and you can see it sort of configures to the prostate not too badly, but the yellow and green, there's still a bit in the rectum and quite a lot of radiation to other parts of the body. So it's better, but it's not perfect. What we did in Britain when we established 3D conformal radiotherapy, as I said, was escalate the dose. And the major British trial for dose escalation was called RTO1, and that was where we took the dose from 64 gray to 74 gray in the now familiar 7.5 weeks. The initial report of RTO1, which was published about 3 years ago, suggested that there was biochemical benefit from 74 gray compared to 64, although we're still waiting for the final survival publication. Despite the fact that it's only an initial publication, 74 gray using 3D CRT or IMRT was recommended by NICE in the guidelines to be the appropriate standard for patients with localised prostate cancer in the UK. And most departments will now use that. And that's the slide from ASCO, which actually has shown that. It shows a 12% improvement in biochemical disease-free survival. All risk groups, but perhaps mainly in high risk and intermediate risk and less in low risk groups. And it was noted that with 3D CRT, with a higher dose, there was a small but significant increase in long-term side effects. That's because the total dose was higher. And for those of you who've seen patients after radiotherapy, you'll know this is the type of toxicity we accept with 3D conformal radiotherapy. The acute cystitis, urethritis, proctitis, and fatigue, the long-term risk, including rectal stenosis, bowel obstruction, rectal bleeding, urethral stenosis, about 2%, maybe a bit less. There is a risk of impotence, no question about it, perhaps 50-60%, depending on how you measure it, but that tends to occur over a year or two later, and a small risk of long-term incontinence. So that's sort of where we've been. For the rest of the talk, I'll talk about where we're at and where we're going. Post-operative radiotherapy. We've already had some discussions today about surgery, about positive margins, and there's a whole issue about, is there a role for radiotherapy after prostatectomy? Is there no role at all? Should it be given in the adjuvant setting, relatively straight away afterwards, or perhaps given a salvage on relapse at a later date? There have been some trials, they're referenced on the slide, suggesting that there may be some benefit of adjuvant radiotherapy compared to observation, but only biochemically, not in overall survival, and at the expense of some increased toxicity. Not surprisingly, adding both surgery and radiotherapy together. There haven't been any trials assessing whether hormones have a role to play in these patients, and on a consensus survey done a few years ago, there wasn't any consensus. As you can see, half the oncologists in the UK would offer post-operative radiotherapy to someone with pathological T3 disease, and half wouldn't. Back to equipoise, John. If you've got equipoise, you need a trial. So Chris Parker, who was here this morning, his other string to his bow is the Radicals trial, which he's the main mover in. And that is a trial to assess immediate versus salvage radiotherapy, and also to look at whether or not there's a role for hormone treatment given with the radiotherapy after surgery. I promised I wouldn't show any slides saying they're too busy. This is too busy, so I've made this one instead. The last slide was the whole Radicals trial schema. I've boiled it down into the two key parts of it, because the Radicals trial involves two decisions, or two randomizations. Firstly, should the patient be randomized to early, immediate radiotherapy after the surgery, or deferred, late salvage radiotherapy when they fail? That's randomization 1, the radiotherapy timing randomization. But the second question is if they're having radiotherapy in this setting, would there be extra benefits from the addition of hormones? And therefore there's a second randomization, which is done at the time of radiotherapy, to no hormones, hormones for 6 months, or hormones for 2 years. These are the eligibility criteria for the Radicals trial. The top one's obviously quite clear, but I'd like to just focus on that middle row about the radiotherapy timing randomization. It's a trial of post-operative. It's not a trial for rising PSAs after radiotherapy. You have to have a very small post-operative radiotherapy, and it can't be rising, because if it's rising, by definition, your radiotherapy is salvage. So this is radiotherapy given relatively immediately for high-risk patients. It is not radiotherapy for patients who have developed a rising PSA after the operation, and that's a subtle difference. This is about adjuvant for high risk versus salvage for proven recurrence. I'd like to spend 5 minutes, if I may, talking about perhaps the most important trials that's come to prominence over the last year, which is the MRC PRO7 trial, which both John and I were involved in, and that's looking at radiotherapy for locally advanced disease. Now, going back again to the 80s and 90s, there was again not a lot of consensus. An early MRC trial done in the 80s tried to look at using radiotherapy alone versus hormones in the form of an orchidectomy versus a combination of both for patients with locally advanced disease. But it didn't accrue very well, it closed very early, because of the small numbers, no conclusions could be drawn and no survival benefit was therefore shown. There were some trials in North America and Europe. They actually compared radiotherapy alone versus radiotherapy and hormones, and they both showed benefit to the radiotherapy and hormones arm. But a lot of Europeans in particular said, well, all of that benefit could be due to just the hormone treatment. And actually, you might not need the radiotherapy. Patients would do just as well with hormones alone as they would with hormones and radiation. And again, one of these other consensus surveys that was done in the 1990s of oncologists and urologists in Canada and Britain, over 60% felt the utility of radiotherapy in locally advanced disease had not yet been established. So, equipoise equals trial. And this is the MRC PRO7 trial. And you can see there, this is a trial for patients with locally advanced disease, either T3 or T4, or T2 disease with high risk factors such as a PSA over 40, or a Gleason score of 8 or more, and a PSA of 20. And they were randomized to continuous ADT or continuous androgen deprivation and radiotherapy. The ADT could be orchidectomy, or it could be LHRH analogues, but because it was orchidectomy, therefore the drugs were given for life. So this is lifelong hormones, not 2 years or 3 years or 5 years, it's lifelong. Anti-androgens were mandatory to prevent a flare, but could also be given long term, so CAB, maximal androgen blockade, was acceptable but not mandatory. The radiotherapy was an American radiotherapy regime. This was a consensus thing, so it was prostate and pelvis, 5 weeks to the pelvis and prostate, plus 2 to 2.5 weeks to the prostate alone. But there was a get out of jail card for the UK. Patients were allowed to give radiotherapy to the prostate alone if they felt it was inappropriate to have the whole pelvis irradiated, and a CT scan had shown they didn't have pelvic lymph node disease. The trial was activated in 1995, and I've highlighted that first line because the sample size was based on the assumption that there'd be a 35% 10-year survival for these patients. At the time, we were quite nihilistic about locally advanced prostate cancer. It was thought to be incurable disease, and the treatment was palliative. And therefore, you would die of it, albeit in a few years' time. However, those deaths, those events, those relapses just didn't happen. And therefore, after 7 years, they had to recalculate the sample size up to 1,200, and which meant the study went on until 2005 before it closed. Last year, the interim analysis was performed and the results were disclosed. Now, my understanding is that the final analysis and paper won't be until 2012, although Matt Sides is here this afternoon. I'll ask him about that because there's a possibility it might be coming out sooner than that. And this is a trial which shows how wonderful we are in the UK. Britain saved this trial. The orange is Canada, the yellow is America, the green, which you can't see, is America, and the blue is the UK. So this trial was struggling until 1999, and then the MRC joined, and as you can see, they basically dragged it kicking and screaming through, and by the end we had in almost more than 2/3 of the patients. So this is a great success story for clinical trials in prostate cancer in the UK. The patients were well matched. They were mainly T3 rather than high Gleason scores, although there was the mix of PSA levels was about a third below 20, a third between 20 and 50, and about a third or a quarter above. Of interest is if we just look at the UK patients, about a third, or more than a third, actually elected to give prostate-only radiotherapy. And that may cause some problems when we come to analyse this in detail in the future. Of the American and Canadian patients, they all got whole pelvis. And here is the slide that sort of made all the the difference has caused all the interest. And this shows a significant benefit in overall survival at 7 years. And you can see it's a benefit of about 8% at that time. But you'll also see that the 10-year survival is more like 60% for patients on hormones and not the 35% that was predicted back in 1995. So that, in general, these patients were doing better, but they were doing even better if they had radiation as well as the hormones. The differences in deaths were all due to prostate cancer, which meant that the disease-specific survival was even more marked, with a 90% 7-year disease-specific survival compared to 79% for patients on hormone alone. And what I find very interesting is that we've always been quite cautious about using pelvic radiotherapy with much bigger fields, taking in the bowel and more of the bladder, because of the risk of toxicity. If you look at the yellow column there, the differences between toxicity between the hormone alone group and the hormones plus radiotherapy group are almost negligible. I think it's 1.2% bowel toxicity versus 1.6%, and for GU toxicity, it's actually 2.3% in both arms. So that's very interesting, suggesting that with modern radiotherapy techniques, it's much safer to give whole pelvic radiotherapy than we thought, and perhaps we don't need to get too hung up on should we be using IMRT for pelvic lymph nodes. So that's a very relevant question in 2010, because as I've said, there has been a significant variation in current treatment practice, and this trial and the recently published Vidmark Swedish trial, we've now had 2 studies in the last 18 months showing the benefit of radiotherapy in addition to hormones in locally advanced prostate cancer. What's interesting though is that the PRO7 was for prostate and pelvic radiotherapy. The Swedish trial was just prostate radiotherapy. So how we actually use the radiotherapy, yes, we should use it. How we use it, who we should use it on, TBA. I think we need to probably wait for the final paper on PRO7. And before I leave locally advanced disease, we see locally advanced disease not only as a presentation, but also in patients who have hormone-resistant prostate cancer. Patients who have symptomatic local disease having failed hormones. And just to say, radiotherapy can be a very effective palliative tool for these patients. And Omar Din works with me in Sheffield, and he published our series which showed that the palliative benefits could be seen in about 90% of patients if you gave them radiotherapy with symptomatic, locally advanced hormone-resistant prostate cancer. Now, it's 3 o'clock, John, but I was quite late starting, so I need to carry on, that's all right. So, let's come round now to IMRT, intensity modulated radiation therapy. Complicated radiotherapy. It uses inverse planning, which is basically using computer-aided logarithms to actually fine-tune your plan. And multiple non-coplanar beams, meaning usually the beam's all in one plane, but now we can start angling them from different angles. And we try now to duplicate the anatomy with our radiotherapy beams, and we're hoping that the use of IMRT with better contour, better conformed radiotherapy will allow us to increase the radiation dose to the prostate, but not increase the dose to things like the rectum, and therefore not increase toxicity. And this is what IMRT means as a schema. In the old, with 3D CRT, the beam was either black or white. It was either the beam was on or it was blocked. With IMRT, we've got these grades. You can have a bit of radiotherapy to part of the beam, a lot of radiotherapy to part of the beam, or no radiotherapy to part of the beam. And therefore you can sculpture your radiation dose much better. And you can produce distributions like this, and this is an IMRT plan, and you will see, compared to the one I showed you before, to the 3D conformal, it's now starting to conform even better to the prostate, that's the red, and actually there's less dose now to other parts of the body. So we've improved our dose distribution without actually compromising the dose to normal tissues. Hand in hand with IMRT goes IGRT, or image-guided radiation therapy. When we're using increasing doses, accuracy is obviously essential, and therefore to eradicate the day-to-day variability, we are using daily X-ray or ultrasound visualization of the target volume to ensure the patient is set up exactly the same every day, every fraction. There are various ways of doing image-guided radiotherapy. There are the non-invasive ultrasound methods, which are simple, relatively cheap, but may not be as accurate as what most IGRT is, which is onboard imaging using either kilovoltage or megavoltage X-rays. You need radio-opaque seeds to do that, and you use systems like VMAT, electrosynergy, or tomotherapy to achieve that. Now, what this enables us to do, the use of IMRT enables us now to actually look at can we increase the dose of radiotherapy further, but because we're British, what we're trying to do, which is different to the Americans, remember the American oncologists are paid per fraction. So that's very important. The more treatments they give, the more they get paid. It doesn't work like that here for me. We get paid the same. So what we're thinking of doing is not just increasing the dose, but actually shortening the time. So rather than having a higher dose over 7, 8, 9 weeks, a higher dose over 4 weeks. So what the CHIP trial, which is currently open, is doing is escalating the dose, but also shortening the treatment time. So the standard arm is group 1, 74 gray and 37. There are 2 experimental arms. Group 3 is the biological equivalent of 74 gray and 37, given in a very compressed fractionation scheme. Group 2 is a higher dose, approximately near 80 gray, but given over 20 fractions, like 60 and 20. And this trial has again shown that in terms of clinical oncology and prostate cancer trials, we do recruit really well in the UK. The blue line was how we were supposed to recruit. The purple line is how we've actually recruited. And this trial is going to close well ahead of schedule. What IMRT enables us to do, as I've just said, is sculpture, contour the radiation dose much more accurately to our targets. So, from the bottom 2 pictures you can see how well we can do it for the prostate, but in the top pictures it's also about how well we can do it for lymph nodes. Now that brings me to 2 questions that I was actually asked to cover during my talk. So question 1 was, should local radiotherapy departments be giving men the choice to travel to receive IMRT? And question 2 was, is there any evidence or gathering evidence for radiotherapy to lymph nodes? I'll take question 2 first, because I've sort of covered that with PRO7. And the thing is that for high-risk patients, particularly locally advanced disease, there may well be evidence now that we should be treating the pelvis in addition to the prostate. But what we probably don't need to do is use IMRT for that. Whether you should have IMRT for your prostate, I think what I would say is that 74 gray and 37 is very safe using conventional radiotherapy. And I don't think people should feel they're being denied anything if they get 74 gray. But if you want to have cutting-edge radiotherapy, most departments now who are using IMRT outside the trial are doing that to start to dose escalate to 76 and 78. So if you want to push the envelope, yes, but in terms of 74 gray and 37 fractions, the nice gold standard, that's actually quite a safe and effective dose given in your local department with 3D CRT. Okay? Right, brachytherapy I shall mention in a few slides. I'm sure you're all familiar with brachytherapy. The use of radioactive seeds or rods inserted into the prostate with a theoretical advantage of higher dose to the prostate, lower dose to rectum, and fewer visits for the patient, although sometimes the higher prostate dose can lead to urethral complications, which is why a recent TURP is an absolute contraindication. That's what a radiograph of someone who's had a LDR, low dose rate, brachytherapy insertion looks like. Those are permanent seeds, they're lifelong, they're usually iodine 125, This began in Seattle about 20 years ago, so we now have some good long-term follow-up. Unsurprisingly, the best outcomes are for the very early cancers. The control rates are very similar to prostatectomy, but there are increased urinary side effects, but fewer bowel side effects compared to external beam. The good outcomes, unsurprisingly, are for patients with low PSAs, low Gleason scores, early stage, but that doesn't mean to say it's no good for intermediate or high risk, and this is pooled data from 3 UK centres from the 2000-2007 for intermediate risk prostate cancer patients, and they show that the 3 and 5 year biochemical relapse-free rates were very high, in excess of 90% at 3 years and around about 90% for 5 years. The only predictor of inferior outcome in this series was a PSA of over 10. More recently, people are looking into using different type of brachytherapy, HDR, high dose rate. This is not a permanent insertion. This is more like what we use in gynae oncology, which is putting in a short burst of high dose rate radiotherapy. Catheters or rods are inserted into the prostate, and the patient is connected to a machine, and high dose rate sources are then go out of the machine into the patient, stay there for a little bit, and then come out again. It's all disconnected, and off he goes. That uses iridium-192. This is being used more and more as a boost in combination with external beam radiotherapy, but there are some studies now starting to look at HDR as monotherapy. You can't give it all in one dose though. Unlike the low dose rate seeds, it's not going to be a one-stop shop. It'll be at least 3, probably more fractions, maybe 9. And whether that's a great advantage having to go and be hooked up to this machine 9 times, we shall see. And there are some reports that this may have a higher rate of GU toxicity. So HDR brachytherapy, again, is something which is coming up. I need to talk to you about protons. We've heard about robots in the States. Protons are to US radiotherapy what robots are to US prostate surgery. This is where people will travel across the continent to get their protons. What are protons? Protons are particles which can be produced by a proton generator. They're very high energy and they behave differently to X-rays, which is what we use for conventional radiotherapy. So the blue is conventional radiotherapy, and if a radiotherapy beam hits the surface of the patient, it gives about 80% of the dose at the beginning, about 100% about a centimetre below, and then drops off. So you have to put lots of different beams in from different angles to add up in the middle. With protons, you hardly get any dose at the beginning, and depending on the energy of the protons that you choose, all the radiotherapy energy is deposited at, in this case, about 15 centimetres below the patient's skin. So you actually have a beam which impacts, does nothing, and then wallop, the dose is all down here. Now that can suit something like the prostate, ideally. And there are 2 pictures. The one on the left is an IMRT distribution. The one on the right are 2 prostate beams, one from the left, one from the right, adding up in the middle. And this one is a IMRT prostate beam, and then at the bottom we've got a beautifully contoured distribution, which is a combination of a proton beam from one side plus some external beam radiotherapy. And you can see with that, you actually get a really fabulous dose distribution which conforms to the prostate and minimal dose outside the prostate. It looks wonderful. However, it is unbelievably expensive. The machine is even more than a robot, probably about 2 or 3 times as much. The price of proton beam therapy is almost double IMRT, which is even more than conventional. And in the American analysis that was published last year, it said the improvement in survival, the quality-adjusted survival in quality-adjusted life years was minimally improved. And this was the conclusion of the American investigation. They said even based on the unproven assumption that would permit a 10-grade escalation of prostate dose with protons, it is not cost-effective by current standards. Whether that will stop Americans having protons for their radiotherapy is another matter, but even the Americans think it's not cost-effective. And that is a cyberknife. Back to the robots, back to the car adverts. It does look like that one painting the car, doesn't it? But I need to tell you that there's more than one way to give stereotactic radiotherapy than a cyberknife. Stereotactic radiotherapy really means giving a very small volume of radiation using a very pinpoint accurate beam, and you're trying to almost ablate the prostate by using a high dose in very few fractions. It's almost like trying to do a surgery on it. You're not trying to irradiate it for cure, you're trying to ablate it. There is very limited data for the use of stereotactic radiotherapy in the treatment of prostate cancer. And the first thing to say, therefore, is that any patient having this in prostate cancer anywhere in the world, to be honest, should be part of some form of research protocol. A review of what literature exists suggests that doses of that, 33 to 38 in 4 or 5 fractions, either daily or alternate days, can be given safely. And it struck me just how similar that was to Larry Olivier's 36 in 6. So what goes around comes around. Stereotactic radiotherapy could only be used as routine if we get the evidence to support it as being at least as safe and as effective as existing treatments. If that was the case, though, it could become a very acceptable alternative technique used instead of 7.5 weeks, 4 weeks, whatever, IMRT or brachytherapy, or even as an alternative to open laparoscopic or robotic surgery. But it is just a research tool. I am not aware of any unit in the UK doing stereotactic radiotherapy for prostate cancer at the present time. And I wanted to finish by just, in 60 seconds, talking about hormones and prostate cancer, because let's not forget how valuable radiotherapy can be for these patients. So it could be local treatment, it can be wide field, it can be systemic. By that I mean the use of radiotherapy, local radiotherapy for bone metastases, such as a single fraction of the pain. And I highlight that we can use it for spinal cord compression. We usually use it for a week, but there's a brand new trial opened about a month ago. First patient entered in Sheffield, in the country, about 3 weeks ago, looking at using just 1 fraction for spinal cord compression as opposed to 5. That's the SCORAD trial, so that's ongoing now. But as well as using it for localised pain in one area, we can use wide field radiotherapy if you've got multiple pains. Hemi-body radiotherapy is old-fashioned. I am old-fashioned. This has now been superseded by chemotherapy, and yet, would I have a single fraction of hemi-body radiotherapy to make my pain better, or 10 cycles of Taxotere over 30 weeks? Particularly when I can get 80% pain relief from my single fraction, and there's evidence it prevents further pains in the future. I accept it can make me a bit sick, but by Jove, so can Taxotere. And then finally, looking at radioisotopes, they've sort of fallen out of favour. Chemotherapy, bisphosphonates have moved in, but they're still a valuable tool. Things like strontium can give you about 70% pain relief. They can be very durable. They can prevent new lesions arising, but there are some drawbacks. They can cause bone marrow toxicity, and if you're not continent, there are major problems with radiation protection. So, that's radiotherapy as was, as is, as will be, and I'll leave you with a quote from that well-known prostate cancer patient, Bob Monkhouse. Thank you very much.
Peter, thank you very much for a very comprehensive review of radiation treatment. As I said to you, the subtext of this meeting is new directions in treatment and care. I often listen to radiotherapists speak, and we all see those diagrams of how you focus the beam. But the second half of your talk there really took us forward and showed us the new ways that we are going. One question for me before I throw it open to the floor. Why do you think the radioisotopes have fallen out of favour? Because they were incredibly useful from the way I saw them.
First of all, marketing. Been poorly marketed. Drug companies have marketed very well. Secondly, to give them The oncologist has to have an RSAC license, and a lot of the old ones all had their licenses. I've got a license, but very few have got licenses, and they're quite hard to get now. And for some reason, they're not that expensive, but they are a bit more expensive. But no one's really pushed the case. I think they're a perfectly acceptable treatment, but they just seem to fall out of favour.
We used to use a lot of it in Sheffield. Hands up, anyone in the room who knows in their department whether they use strontium? There's a third of the room at least, isn't it? Interesting.
In Sheffield, we've got access to bisphosphonates because we've got the bone research unit there, and I think bisphosphonates have actually taken away a lot of the old business for strontium.
Any questions for Peter? I've allowed the session to run on because I think those two presentations were really interesting and have provoked a lot of questions from you. Question at the back.
In the Radiotherapy trial, I presume that the patients who receive radiotherapy just get into their prostatic bed.
Yeah.
Do you think there's a case where they should receive radiotherapy for their lymph nodes, considering the vast majority of prostatectomy is under a limited lymph node resection?
I think we'll need to start with the prostate bed. I mean, the problem with that is there's really no experience whatsoever about using post-operative whole pelvic radiotherapy and what kind of additional toxicity you get with that. So I think we'll probably start off with the prostate. I don't think you find many takers for that at the present time.
Any other questions for Peter? Yes, please. Tell us where you come from.
I'm Joe. I work at Lark's Hospital and prostate cancer specialist. I just want your view about PSA pumps, brachytherapy, and when do you recommend having bumps?
PSA bumps is a very, very well described phenomenon, 18 to 24 months. Now, I don't do brachytherapy, but my colleagues who do just say you just let it go. And then let it go. If it doesn't go down, then you can think about reinvestigating. But usually, 18 to 24 months, most brachytherapy patients will have a bounce. You work with dilipottomy in Leeds, don't you?
Yes.
What about how they manage the bounce in Leeds?
Oh, I don't know. They still have patients post-procedure.
Okay. I mean, I think it's thought to be a vascular effect. It's very common, and the most important thing is not to don't panic the horses.
Don't panic the horses, there's a message. Yes, please.
I'm a radiotherapy nurse from Edinburgh. Do you think all men with prostate cancer should get NICE guidelines 74 and 37?
All men with localised prostate cancer outside of a clinical trial.
Yeah.
Right. I think that is a safest option. I think that is proven to be safe and effective. I think I would only treat outside that for we're on a protocol. And we looked at how we're going to use IMRT after CHIP, and we're going to use it to dose escalate and go above 74 gray. But our standard outside that protocol will be 74 and 37.
What about below?
Below?
Yeah.
In terms of hypofractionation, you mean?
Yeah.
We used to use 55 and 20 all the time in Sheffield. We are really interested in using the 57 and 19 and 60 and 20, but I think we need to wait for CHIP. We debated this only last night at our meeting whether we should use the off-trial or not, and the consensus was not to do it off-trial until we get toxicity data from CHIP.
Neoadjuvant hormones with it?
With neoadjuvant for high-risk patients, yes.
What do you do in Glasgow?
In Edinburgh,
Sorry.
we actually have two different fractionations. We do the 74 and 37 for the high-risk younger men below 70. For the lower risk men, we've actually dose escalated from 55 and 20 to 57 and 19. They do get neoadjuvant hormones.
For the high risk or for all of them?
All of them get neoadjuvant, and then some of the higher risk carry on hormones.
Who gets 19 fractions?
The lower risk.
Lower, and you say, I would not do that. Because you're giving the low-risk patients the high fraction size with a potential higher risk of late complications, and they're the patients who might actually live the longest. So I would actually, we debated this last night, and we felt unhappy about using that sort of regime, particularly in our low-risk patients. Because in theory, you could be increasing their late toxicity risk.
Let's carry on questions over tea, if you don't mind. I'd like everyone back here for 3:45. Thank you very much for your attention. Thank you, Peter.
You're welcome.